Hello, this is David, and this video clip is a rudimentary introduction to the notion of Barrett's esophagus. So, if we think of this structure that I drew here as the esophagus and pharynx, and sort of this is the pharynx right here, with shown more distended and has some skeletal muscle input, and then this tubular structure here is the esophagus, and then this is the diaphragmatic crux through which the esophagus passes, and right here is the stomach shown. And so the tubular esophagus, relatively long structure, if I recall from medical school, it's maybe about 40 cm from the teeth until the crux, roughly. But I could be wrong about that. But I think that's the right ballpark. And then once it goes beyond the diaphragmatic crux, you see the fundus of the stomach, and then the body of the stomach, and here the pyloric antrum. And so, and of course here the esophagus, shown with an E. And if we take a cross-section of the esophagus right here, what you'll see, if you just look at it grossly, if you look grossly at the esophagus in cross-section, what you see is that it lacks a serosa, so that there's no serosa, and it has, let's look at the levels from the outside in. It has an outer longitudinal muscle, an inner circular muscle, and both of these make up the muscularis propria. And then here, this white layer, this is the mucosa. And if you pass in a scope, let's say you put a fiber optic endoscope looking in, so let's say you're looking endoluminally, or if you're looking here from inside the lumen, what the wall looks like all around you is white. And that's because the esophagus is lined by something called non-keratinizing squamous epithelium. And if you were to take a biopsy of a little piece of the inner lining here, so what I've shown in green, if you were to take a biopsy of that, what you see is this structure called squamous epithelium. So it's just this inner lining. And squamous epithelium is a given epithelial type, and the cell bodies are shown, or the cytoplasm is shown sort of in white, and the nuclei are shown in light purple. And what you see is the cells are arranged in several levels in this layer. There's several levels of them. And they seem a little bit to go from a vertical orientation. They seem to migrate as they go up. This is the luminal side, and then this is the side facing the muscularis, facing the muscularis mucosa and then the muscularis propria. So if this is the luminal side, as the cells progress from their basal aspect, because there's a basement membrane here, as the cells progress upwards from their basal aspect up towards the luminal aspect, they progress from a more or less vertical orientation ultimately to acquire a horizontal orientation, but there's no keratinization. And so, but what I want you to see is that the cells have, within this epithelial layer, they have an organization. They have like this sort of upward organization. It's very organized. And the nuclei are very organized. And you see they don't step on each other's toes. They're nicely spaced one from the other. You see you have good distance between these nuclei. So there you go. So that is what's called a squamous epithelium. And because squamous epithelium is glycogenated grossly when you look at it microscopically, you see the cellular detail. But grossly when you look at it, for example, at endoscopy, or if you were looking at a surgical specimen of normal esophageal mucosa, it looks white. Now, if we take a cross-section here, right here, within the gastric fundus, what you see is a kind of columnar epithelium that's called gastric fundic type columnar epithelium. And these are a different kind of cell. The lining, the epithelium, in contrast to squamous epithelium, the epithelium in gastric fundic type of epithelium is a single cell layer, and the cells have either like a cuboidal or a columnar layer, and it sort of looks like this, what I've shown, and the cytoplasm here I've shown in red, and the nuclei once again in purple. And once again, it's a very nice organization, but they're different. And I just want to emphasize that this is important because this is a squamo-columnar transition zone, a squamo-columnar transition zone at the gastroesophageal junction right here. This is the junction between the tubular esophagus and the gastric fundus. And at that point, point of transition between going from esophagus to stomach, you also have a transition of the mucosa type, where you go from squamous mucosa that line the esophagus to columnar mucosa or epithelium that lines the gastric fundus. And we can't repeat that enough. So squamous epithelium lines the esophagus, gastric type columnar epithelium lines the stomach, and in between, just at that very smidgen in between, the borderland here, which I'm showing you here, that would in essence be a squamo-columnar junction. And normally, in the normal situation, the anatomical transition between the tubular esophagus and the stomach, which is at the diaphragmatic hiatus, at the crux, at the diaphragmatic hiatus, that should be your squamo-columnar transition zone. And endoscopically, your squamous epithelium looks white, and your gastric fundic type columnar epithelium looks red, and you see this abrupt transition from white, which I'm showing here, to red, and it's sort of like a clean line. So that's what the endoscopist would see. So that's the normal situation. There's a very important principle in medicine that as epithelium, which is the lining of structure, starts to get irritated, it could change. And that change is called metaplasia. Metaplasia, it becomes something else. So, for example, squamous to columnar transition is a form of metaplasia. And the next step is something continues to regenerate and regenerate in the context of ongoing insult. The next step beyond metaplasia is mutations or bad things could start to accumulate in the DNA, and then the nuclei could start to go bad, and that's called dysplasia. And then if the nuclei get worse and worse as ongoing repair and regeneration and more division cycles, which enables more errors to potentially happen, eventually you could get something called dysplasia, and dysplasia means bad growth and sort of pre-malignant growth, and after dysplasia, if there's continuing ongoing insult and continuing ongoing injury, then you could actually get carcinoma. So the sequence that I want you to keep in mind is the metaplasia, dysplasia, carcinoma sequence. So in the context of Barrett's esophagus, what happens here is that a person, for example, might have chronic sustained reflux esophagitis. And after time, because of the ongoing acidic insult, you put down the scope, and what you start to see is a red mucosa within the tubular esophagus. And that doesn't seem right, because squamous epithelium normally should be white. So what's this red doing here? So something's changed. So this may be a metaplasia. Something's changed. When you look at it in the microscope, what you see, lo and behold, instead of seeing normal squamous mucosa like here, what you see instead is something like this. And what this is another kind of columnar epithelium. But this columnar epithelium is really out of place, because it does have these, sort of columnar or cuboidal type of cells that are totally not like the squamous, so it's a change, and yet they're in the tubular esophagus, which is wrong, it shouldn't be there. But there's also another kind of cell that I've shown here in blue, and those are cells that contain acidic mucins. And those cells are called goblet cells to the pathologist. And acid mucins are not present in the stomach. Acid mucins are only present in the intestines, and if you want to go into detail, the type of acid could either be sialated or sulfated, so more like a sulfuric acid, so sulfacids, or there could be sialic acids, and then, people talk about complete and partial, but all of that's detail that you don't need to know. But you start to get, within this abnormal region, you start to get metaplastic, so altered epithelium, metaplastic epithelium, which is columnar epithelium with goblet cells, in other words, intestinal type epithelium. So what's Barrett's esophagus? Barrett's esophagus is intestinal metaplasia of the tubular esophagus. Now, some people think, and that's why I've shown with this green line, some people think that the metaplasia first goes to a gastric fundic type because it's more appropriate to the regional. That first, the esophagus undergoes a gastric fundic type metaplasia, and then it goes to a intestinal type metaplasia. But that's details. The only thing you need to know is that in context of chronic reflux, you've got to watch the patients, because at some point they could get a metaplasia. What's a metaplasia? The presence of small intestinal. What's a Barrett's metaplasia? The presence of small intestinal type columnar epithelium in the tubular esophagus, parenthetically where it should be squamous epithelium, but there are goblet cells. In other words, it's clearly intestinal type. In other words, it's more than just gastric metaplasia. It's actually intestinal type metaplasia. Okay, so who cares? Does Barrett's metaplasia hurt? No. Does the patient feel it? Not beyond the reflux. And in fact, it may in a sense be an adaptive change, because maybe this type of epithelial lining is better at handling the acid of the stomach than this. After all, the stomach is lined by a columnar epithelium, so maybe this metaplasia represents an adaptation to try to deal with the acid. So then what's the problem with Barrett's? Leave the patients alone. And the answer is you can't, because the Barrett's could progress. So Barrett's alone doesn't hurt, it doesn't really bleed, and it doesn't do anything, except it could change in the face of ongoing insult. And what could change? And maybe even people believe it could happen even now. It could develop some autonomy, and even not in the face of ongoing insult. It just sort of acquires a life of its own. So the next step it could do, so if you see here I showed the Barrett's, which is sort of columnar epithelium. The cells are shown in red. I drew a little absorptive brush border here. The nuclei are in purple, and you have your goblet cells here, which I'm showing here and here. Here. The next step is the nuclei. The next step in the progression is the nuclei could start to get bigger. The nuclei could start to get darker. We call that nuclear hyperchromasia. Increased nuclear to cytoplasmic ratio, which means the nuclei get better and bigger, and then the nuclei in relation to the cell, and then the nuclei could start to be crowded. This is dysplasia. And the first step is, we could call this low-grade dysplasia. So that's worse. So let's say you're watching this patient and you're doing biopsies and you see Barrett's esophagus. The next step in the progression, you could see, uh-oh, now things have moved on. Now I'm starting to see nuclear unrest. This is dysplasia. And this is a big step, because this is metaplasia right here. This step, this Barrett's esophagus, and now we've moved, as the nuclei start to get irregular, we're starting to get pre-malignant changes, and that's dysplasia, and the form, in this context, what we would call that is Barrett's esophagus with low-grade dysplasia. The next step would be, you see, to go from here to here. The nuclei start to get even worse, even bigger. And then the nuclei lose their orientation, because the nuclei have a nice orientation that you see here. The nuclei are perpendicular in axis to the basement membrane. And here they're not. They sort of have all sorts of orientations. And so loss of polarity of the nuclei, pleomorphism. You see I've shown the nuclei, they have all, pleo means many different types. Nuclei have different shapes and sizes. They're all sorts of irregular. You could get a typical mitotic figure. See, I showed a mitotic spindle here. So the nuclei start to get more and more irregular. And this we could call Barrett's esophagus with high-grade dysplasia. And then the next step would be that after the high-grade dysplasia, the cells could actually lose their respect for the basement membrane. You see, the basement membrane used to be here, and the cells just start budding off and migrating away, and they break down the basement membrane, and they escape, and they go where they shouldn't, and now we're beyond high-grade dysplasia, now we're in cancer. And what you see clinically in cancer, so what you see clinically, there's also a clinical progression for the endoscopist, where the normal esophagus is wide, and then you have an abrupt transition to red mucosa as you enter the stomach in the right anatomical location, which is the gastroesophageal junction, which is at the diaphragmatic crux. When the patient develops Barrett's metaplasia, what you start to see is a red epithelium within the tubular esophagus. When the Barrett's become dysplastic, you really don't see anything grossly, and that's why the only real way to tell the difference between Barrett's and dysplastic Barrett's, especially low-grade dysplasia, is with a biopsy. But then when it finally progresses to cancer, you can actually see a mass right here. And then usually the mass is in the context of Barrett's. And that's the reason why this type of carcinoma, because you see this is an adenocarcinoma, because it arises from columnar epithelium, tends to be in the vicinity of the gastroesophageal junction, because that's where Barrett's usually arises. And now you understand why adenocarcinoma of the esophagus is usually in the distal esophagus. Whereas, parenthetically, there's a different kind of cancer of the esophagus called squamous of this cancer of the esophagus, and that's more evenly distributed and often higher. Is And by the way, I know I'm engaging in a lot of egregious oversimplification. The last comment that I'll just make is, so what's the clinical sort of outcome of this? Well, if a patient has reflux esophagitis, this provides a rationale to treat so that you don't get Barrett's. But you don't have to surveil the patient, because reflux itself isn't not a lot of those patients will get cancer. But if you do a scope on somebody and you see Barrett's, even metaplasia, so Barrett's is just a metaplasia, even without the dysplasia, so it looks like this, a little bit of red, and a biopsy looks like this, non-dysplastic. The nuclei are not bad, but it's just columnar epithelium, intestinal type columnar epithelium within the tubular esophagus. Because there is a chance of progression, there's something that you have to do with that patient, and here's a big word, folks: surveillance. Let's hope I could spell it right. Surveillance. So this patient needs surveillance. And all I'll say for the sake of this discussion is that if it's just Barrett's, the surveillance interval could, let's say, be 1 year. There's some latitude. If it's just plain Barrett's, maybe even 3 years. And this is not a clinical recommendation. I'm just giving this for ideas. If you have low-grade dysplasia, then that's already a pre-malignant lesion. So then you could either surveil the patient very frequently, like every 6 months to a year, or you could try to ablate, remove the Barrett's. And there's different kind of ablation technique, and you could just ablate the mucosa. For example, there's laser ablation, and there's something called endomucosal resection. Once the patient has high-grade dysplasia, what I was taught when I was a student is high-grade dysplasia is so dangerous that is an esophagectomy. You must remove the patient's esophagus because they could get cancer, and the cancer could be very lethal. And that was really the teaching when I was a medical student. They told us that it's very important for the pathologist to be able to distinguish low-grade dysplasia from high-grade dysplasia in the context of Barrett's, because the implication of high-grade dysplasia would be it necessitates a surgical esophagectomy. That may be, depending on how one reads the literature and depending on where one works, starting to change a little bit. There's new techniques called endomucosal resection, but still. At the very least, high-grade dysplasia in the context of Barrett is a very serious pathological diagnosis because it might necessitate an esophagectomy. And look, it's not a malignant lesion, but it's a pre-malignant lesion. And the other thing that I want you to note is, in high-grade dysplasia, it doesn't necessarily look any different than Barrett's alone to the gross endoscopist. The only persons that could tell you, all you just see is this red within the tubular esophagus. The only persons that could distinguish whether it's, high-grade dysplasia like this or just Barrett's like this is the pathologist. And that's why when you're a gastroenterologist and you see red mucosa in the tubular esophagus, you must do a biopsy, because you want to know, is it Barrett's? Is it Barrett's with low grade? Is it Barrett's with high grade? And if it's high grade, that's a severe decision point. And that's the end of this introduction. Thank you so much for listening.